Hello, everyone, and thank you for joining us on this episode of the Account and Coca Report. I think the conversation here will be a potpourri of topics, but the general theme will be to contrast the political way of getting things done versus the voluntary and humane way of getting things done, particularly in healthcare. We are delighted to have with us Mr. Jeff Deist, who is president of the Mises Institute, which is a wonderful educational institution that promotes a very noble tradition of economic theory and political thought, a tradition that is becoming more and more relevant each day. Mr. Deist is a great writer, speaker, and social commentator. Prior to taking the helms of the Mises Institute in 2013, he was chief of staff for Congressman Ron Paul for many years, and in that capacity, he gained special insights into healthcare sausage making in Washington, D.C. Jeff, welcome to the show.
Well, thank you, Michelle. It's great to see you just a week after having seen you in person.
That's right. It was great meeting you, your wife, and your lovely daughter here in San Francisco. Jeff, we don't want to talk too much about the Mises Institute, but I really want the audience to have a little glimpse of what it is, because it's unlike your typical think tank, if it's a think tank at all. Mm-hmm. Can you describe just a little bit what it is?
Well, I'll tell you what we hope it is, which is an alternative school of sorts for people of any age, people at any stage in their life who just don't know a lot about economics. And really, that's most people in America today, because it's entirely possible to get through high school, even through college, without a single economics course. And if you do manage to have an economics course in either of those two settings, it may well teach you the wrong things that you need to unlearn, at least from our perspective. But here's the thing. We would be worried. We would actually be aghast if we were sending our children out into the world as young adults, unable to make change at a cash register, unable to write complete sentences and then a paragraph and then an essay, unable to understand algebra, for example. But yet we send them out into the world with little or no understanding of economics, which makes them vulnerable. It makes them vulnerable to politicians. It makes them vulnerable to getting into too much debt, to not understanding their personal finances, all kinds of things. So what we try to do is first and foremost, we openly try to present a certain very, very generally, very broadly stated school of economics, known as the Austrian school. It's not monolithic. So we do have a particular axe to grind. We're an advocacy organization in that sense. But we also try to bring economics to people in a way that academia isn't. We're very critical of economics as a profession today. We don't think it's doing much good for people. It has little or no predictive ability. It's simply a gigantic jobs program for academia, for people at the Fed, for people at banks, at investment houses. And it's not serving people. And I'm sure you see some parallels in medicine sometimes when you get frustrated. So that's generally what we are, and we try to be free. We try to have a lot of content, a lot of books for free online at Mises.org, a lot of events and that sort of thing. So the people are interested and they want to learn more. They can come take a look, and it's all online. It's all free, thanks to this double-edged sword we call the digital revolution.
Right. It was a complete eye-opener for me when I stumbled upon the Mises Institute in 2007, I think. And you're right, the resources are absolutely tremendous. And my education began at that point, certainly in economic theory. At that point, it's coherent, it's understandable, it's not a bunch of arcane equations, that completely separate us from the experts who are telling us what to do and what should be done. And in fact, there's a coherent reason why it should not be mathematical, because human beings are not, engines or machines, or, we don't follow the laws of physics. So it's based on a proper, maybe not a complete understanding of the human person, but a proper understanding of how humans make decisions. And that, of course, is very relevant to medicine. And so I was, once I learned the basic economics, then I could see some parallels, as you mentioned, to the world of healthcare, and how, likewise, in medicine, certainly in academia, there's a misunderstanding of what patients are, what doctors are, and what we're supposed to do. And a lot of it tends to be mathematized and put into numbers and formulas and that sort of thing.
Well,
So
maybe this is the single biggest problem in economics today, regardless of your viewpoint or your politics or anything else. Maybe the single biggest problem is methodology. Economics is a social science, which means that the methodology of the physical sciences doesn't apply, or it ought not to apply. So we don't create a hypothesis and go out and test it via empirical data like we're testing a new drug or a new statin or something. It's about human action. And even though humans are made up of cells and molecules, they're not cells and molecules. They are these strange, volitional, irrational animals who do all kinds of things. And even if they do something 100 times in a row, the 101st time they might do something unusual, unlike, let's say, an apple falling from a tree. We think that the profession of economics went off on a very bad tangent a little less than 100 years ago, especially during the Great Depression and the era when John Maynard Keynes came out with his General Theory book, which is still a hugely influential book, and that economics became, as you say, sort of a mathematized system where we create models and we try to fit human action into this. And of course, all of this led to what we think of as nonsense, but what a lot of economists call macroeconomics. And you've written at Mises.org a little bit about the aggregation of data in medicine. Well, this is a problem in economics too. We look at things in the aggregate, and in my opinion, that doesn't always give us a very clear picture of what's going on. It can create an illusion in our minds. And it can also give us, as we saw in the crash of 2008, where we had all these brilliant Ivy League people working at central banks, the ECB and the Federal Reserve Bank in the US and the Bank of Japan, all these brilliant quantitative people saying everything's great, housing market's great, job market's great, nothing to worry about, stocks are great, and they weren't great. So the mathematizing, the application of of physical science methods to the decidedly social science of economics is a big, big problem. And it's one thing that really sets, again, broadly stated, the Austrian school apart from other schools of economics.
So how is it, Jeff, that it hasn't fallen flat on its face? Why does it seem that there's such a dominance of the other economic school of thought? Like as you're saying, and as Michelle is alluding to as well, there isn't even a conversation about anything else in, say, medical school and in many undergrads and whatnot. So, what if they're so wrong? Why have they not been relegated to the dust heap of history, if you will?
Well, that's an excellent question. I wish I had a better answer for that. And they were in many ways relegated. They, meaning Marxists, as early as the late 1800s, and what we would loosely term the Austrian school was dominant right up until the period around the Great Depression in the 30s. But I think what has happened is that a lot of people have jobs in economics of all stripes, and as a result, there's a lot of inertia. There's a lot of self-interest involved in sort of keeping this whole thing going. Whether or not it's working, of course, is a matter of opinion. It certainly works for some people. I think central banking, for example, works for some people. I think stimulus works for some people. It doesn't work for everybody. So that's a question that I think is not yet answerable, because I think we need some time and some history to decide whether this experiment is going to continue forever and ever. Remember, it wasn't so long ago that Francis Fukuyama was talking about the end of history, and the Berlin Wall was falling, and everyone was saying, oh my gosh, now we've got it figured out. And we're not going to have these tyrannical governments around the world anymore. We're going to impose this sort of soft social democracy everywhere, and the whole world is going to see the obvious rightness of our Western ways. And that has not turned out to be true. And so I think that we may well see in the future that what seems obvious and right to a lot of people in politics and economics today is not. And I hope it doesn't take some sort of nastiness like the crash of 2008 to prove that. I'm not cheering for that. I don't have any malevolent desire to be the guy planting the flag in the rubble and saying, see, See, we were right. That doesn't hold any appeal to me. I think there are some very serious structural problems with the U.S. economy and with Western economies with regard to debt and entitlements and all these boring things that people think we can kind of put off into the future. So, a fair question, a fair question on your part, and my only response can be time will tell.
Well, let's go back in time a little bit, and I'm going to switch gear. You worked for a physician, a doctor who happened to be a congressman as well, Ron Paul. For how many years? Were you chief of staff?
About 5 years in two different stints.
Okay. And so you had an insight into, Ron Paul is not known necessarily for, despite the fact that he's a doctor, he was not all that involved in healthcare policy, and probably for good reason. But nevertheless, I suspect that you were involved with healthcare issues, and you saw a little bit how that's happening in Congress. Do you want to share with us some of these insights or experiences?
Well, I mean, the first thing that comes to mind when I think of Ron, Dr. Paul, is that he was an OBGYN for so many years. And what happened was that just as he was finishing medical school, the Korean War came along. And so his friendly draft board informed him that he was likely to be drafted, but if he would sign up and enlist, that they would make him a flight surgeon in the Air Force, which sounded to him like a slightly better alternative to being a foot soldier, let's say, in the Army. So he signed up, and after spending some time over there, he ended up at an Air Force base in San Antonio, Texas. And back then, this is so great, back then they would all rotate shifts at the base hospital. And of course, regardless of your underlying specialty, they would all do tonsillectomies, they would all deliver babies, they would all do appendectomies. It was very generalized in a way that you don't see today. And so when he finished there, earning an extra $2 an hour for extra shifts that he would take on Saturdays at the hospital, $2 an hour, him and his wife, Carol, decided that they would stay in Texas. They liked the warm weather. So they chose this little town of Lake Jackson, and between about Houston and San Antonio, there was one older OBGYN. So Ron went and talked to him in Lake Jackson, Texas. And so they decided that Ron would work for him briefly, maybe during his last year, and that he would retire and Ron would take over. So his first day in the office as an OBGYN, mind you, he was never an employee of anyone. His first day in his office, he had a waiting room full of patients. He had no malpractice insurance. He had no student loan debt. He had an arrangement with the older doctor to slowly buy the equipment. Ultimately, he bought the building. And he had a small staff, none of whom were involved in medical billing. Even the receptionist would take blood pressure or do patient-facing things. So what a remarkable story versus the young people coming out of medicine today. And so, as a result, Ron always had this very independent streak in him. He didn't want to be an employee. And one of the remarkable things about his early practice, imagine no malpractice insurance for an OB today. But one of the remarkable things was that, like all doctors of his era, he had a certain percentage of women in his practice who couldn't pay. They just couldn't pay. And so he saw them, he helped them with their pregnancies, he delivered their babies, and he wrote it off. And this was not considered some noble sacrifice on his part. This was just what doctors did. It was a cash-based practice, and a certain percentage of those women couldn't pay. And and I got to tell a story. Lou Rockwell will not be happy with me, but back at that time, late 60s, early 70s, I guess there was still the term a young girl in trouble. And this meant a girl with a pregnancy and not a beau or a husband or a boyfriend. And so Ron, of course, came in contact with several of these people, and he arranged for Lou and his wife to adopt a young baby from a girl who was having some trouble in life. And that girl today is, I guess, in her 30s, and she is Lou and Marty's wonderful daughter. So it's
oh, that's amazing. I didn't know that story.
A happy story, yeah.
Right.
But you fast forward, and because all of us in Ron's office were very strong libertarians, we had an interest in lots of things. We had an interest in health savings accounts. We had an interest in seeing dietary supplements not monkeyed with. We had a very strong interest in opposing the Medicare Part D prescription drug bill. So we had some interesting fights. One of them was on what some of your listeners will know as the Deist legislation of the early 1990s. Now, this was 10 years later, but that stands for the Dietary Supplement Health Something Act. I can't remember. But the Deist Act was a compromise passed by Congress, and it resulted in that little stamp you'll see on the side of supplements. It says, you're buying your ginkgo or whatever, and it says this product is not intended to diagnose, cure, or treat any disease. Well, one of the compromises of that bill was stamping that little thing on the side. But in exchange, it allowed for a fair degree of freedom in offering supplements which are not FDA approved. So, we thought that Deist was important. It was under attack by then Senator Hillary Clinton, who is really bad on health freedom, by the way. A lot of people don't know that. But one thing that we had going for us in terms of support for health supplements was just the simple fact that baby boomers were getting older. And baby boomers like their supplements. Now, maybe 90% of this stuff in the health food store is snake oil, and okay. But nonetheless, they serve as a large cohort that wants to be able to buy glucosamine and chondroitin for their knees, that wants to buy a coenzyme Q10 for their heart, et cetera, et cetera. And by and large, the baby boom generation believes in supplements and consumes a lot of supplements. So that gave us some support from the industry to guard against attacks on Deist. But let's not kid ourselves. There is an international commission under the auspices of the United Nations called Codex Alimentarius, which is much more active in Europe. And as a result of that, health supplements are much more regulated in Europe. When you go into a store in Germany, let's say, you can only buy little tiny 100 milligram vitamin C's or something like that. So we do have a degree of freedom in the United States because of the Deist Act surviving against some people who would like to attack it. And the number one group of people who would like to attack it are the pharmaceutical industry, because they don't much appreciate having alternatives to their drugs on the market, especially when they spend millions or billions of dollars getting those drugs to market and getting them through the FDA approval process. So one of the most unholy things I have ever witnessed in my life was the passage of the Medicare Part D prescription drug bill in June of 2003. For those who recall, this was a naked sop to senior citizens. George W. Bush wanted to be able to offer seniors something so they would vote for him against John Kerry. Would he have won the 2004 election without Medicare Part D? I don't know. That would be speculative. But what I do know is there was a very, very colorful committee chairman named Billy Tozan. And Billy Tozan was from New Orleans, and he was larger than life, and he was known for cutting corners ethically here and there. He was the chairman of the Energy and Commerce Committee, which had jurisdiction over pharmaceuticals, for one thing. And so he shepherded this Medicare Part D prescription drug bill through the House and Senate and ultimately into being signed. And what that bill entailed was basically the greatest thing that had happened in a long time for pharmaceutical companies, because some seniors, of course, without drug coverage on their private plans, don't have money. And all of a sudden, all these less affluent seniors will be able to buy your drugs, seniors who heretofore could not. So, of course, the pharmaceutical companies were all behind this. And we looked at some of the actuarial tables at the time with the help of the Congressional Budget Office, which I got to put a plug in, is actually an excellent and competent nonpartisan part of the U.S. federal legislature.
The CBO?
The Congressional Budget Office.
Mm-hmm.
So they sort of proved out in an actuarial fashion that the drug benefit we were about to provide to older people based on the aging population, based on life expectancies, would actually cost more in actuarial terms down the road than the original Medicare bill from the 60s. In other words, drugs cost more than doctor visits.
Right.
So it's an actuarial nightmare. It is a big part of what is exploding our entitlement gap in the future, where we have this 200 trillion with a T differential between what we're likely to owe people in entitlement promises, especially Medicare and Social Security, and what we're likely to take in taxes. So down the road, there's a $200 trillion gap that economists have figured out. So,
right. It's funny
Medicare,
that
the Medicare bill is part of that.
We rarely hear everybody's talking now about the drug price crisis. How drug prices have gone through the roof. Hardly is it ever mentioned or timed or connected to the passage of Medicare Part D.
And
it may not be all that clean. It may not be a direct cause and effect. There may be other issues as well. But certainly it seems that, it became acute in the last 10 years, and it so happens that that's when Part D was passed. So.
Well, the Band-Aid approach, of course, would simply to be allow drug importation from other countries. Anyone who's visited Canada or Mexico recently knows that you can buy over the counter far cheaper there, especially with basic stuff like Keflex. But nonetheless, this bill was very unholy. It was literally passed at 2:30 in the morning. Members of Congress were threatened. There was one in particular, a gentleman named Nick Smith from Michigan, who was set to retire, and his son was hoping to take over the seat. And Tom DeLay, some of you will remember that name. He was the infamous House Majority Whip during the years of the Dick Armey speakership in Congress. Tom DeLay basically told him, your son will never be a congressman if you vote no on this turkey. So it was just an opportunity for me as a libertarian-minded person to see just what perverse incentives Congress will put in place and how anti-market the system is.
So how do what do you do about the problem of seniors that aren't able to get certain drugs? I mean, it's such a complicated thing, right? Because you have, of course, folks that are affluent enough to be able to buy drugs, and so their ability to pay, whatever percentage of list price they can pay exists. And then you have this you have this segmented market in terms of what they can pay. Mm-hmm. And clearly whatever existed before wasn't working for that group of folks. And that's why there's this push. I mean, George Bush doesn't wake up just one day. As you said, George Bush doesn't wake up one day just saying, hey, I want to do this. He wants to do this because he can get votes, and there's a sizable portion of folks that want that. So this is a challenge that constantly faces us in healthcare. How do you communicate that to patients? Meaning, don't you have to give them a solution, some type of a solution, or how do you go about making those inroads into that?
Well, I think there's two basic ways. One is that you have single payer, taxpayer provided healthcare with rationing, where we have to say who needs it the most and what drugs ought they to get. And I think the other way is to let the market work entirely. That means no patents. That means bare knuckle competition. That means importing drugs. And it also means creating a generally more prosperous economy that gives people more disposable income. I think that drug prices are in many cases inflated and artificial. So there's the problem for us is that the U.S. wants to take this middle path. We have the worst of both worlds. We don't seem to want to take a market approach, and we don't seem to just want to just throw up our hands and say, okay, we're going to be England, we're going to be Canada, we're simply going to have drugs provided for free with everything that goes along with that. But look, I understand some of the arguments that if the U.S. government was a gigantic buyer, it would have negotiating power, and pretty soon some of these drugs would be a lot cheaper. I understand these economy of scale arguments, but I just have to disagree with them because I have information from people in markets like the UK and Canada where you literally have physicians as employees of the nationalized health service, and you have drugs being provided for free, and places like France where physicians aren't directly employees of the National Health Service, but how much they're paid, how much each service gets, how much drugs cost is set by legislative fiat, and they both have serious problems with shortages. So
do we have
ask a doctrinaire libertarian what to do about something, you get a doctrinaire libertarian answer, which is free it up and let prices fall. But also we have to accept imperfections and limitations in life. When we were young people, we didn't have all the wonderful drugs today. We didn't have all the MRI treatments. We didn't have everything we've got today. And some of these things cost more money than the old-fashioned healthcare we had as kids. But what I truly believe in, what I absolutely believe, is that we need to allow people to pay cash for basic services and let competition among doctors drive that down. I think we need to have high deductible, catastrophic type insurance for most people, especially people under 40, where really your biggest risk is a car accident or a fall. High deductible, cheap, catastrophic only insurance, which just covers hospitalization, nasty things happening, but it's cheap. And then I think we need to have a system of charitable hospitals and charitable clinics and charitable doctors for the truly indigent and poor, and let technology do what it does. Let deflation do what it does. Why is it that things that cost cash, like plastic surgery and LASIK eye surgery, get better and cheaper over time? And why is it that things where the government is involved in mandating insurance, in basically inserting a third-party quasi-private middleman in the form of an HMO or whatever, why do these things seem to get more expensive, longer wait times, etc.? I think the answer is the lack of discipline the market imposes. So,
right. I can't imagine
that's not a political answer for seniors.
I can't believe I'm even pushing back against what you're saying. When you ask, when you're talking about a catastrophic, a little safety net and whatnot, because I think the main problem is to want to have a solution that is on such a huge scale. Mm-hmm. If we want to back, if we're talking about a solution for 300 million people, then of course, at that point you say, well, it's impossible, without a safety net to cover everybody. But since when is it the duty of the government, of the federal government, to provide a solution for 300 million people? It's impossible. And the safety net is inevitably going to be some kind of, is going to be taken advantage of. How can they, decide who's really, who's really destitute and who really needs the help, who doesn't need the help, and that sort of thing. Mm. And the same argument then can be applied to at the state level, because states are quite large. It's millions of people, and so forth and so forth. And then when if you bring it down to the local, the personal level, you go back to the example that you gave about Ron Paul, about how we help each other out. And that's a very natural way of going about things, and people can get together and set up funds, because by then the prices of drugs will be much lower. Especially if we also get rid of all the artificial requirements for regulation. The FDA demands to prove that the drugs are efficacious. All this nonsense that and then the safety net becomes completely irrelevant. The safety net is the community. Is the good side of human beings, which it exists. So long as we remind ourselves that there has to be a good side of human beings. Otherwise, if there's no good side to human beings, forget it. Let's become Marxists and have our human nature re-engineered. But otherwise, there is, and we have to.
But folks, a lot of the advances in medicine, have come not in the attempt to try to create a solution for the entire population per se, right? It's come in in expending vast amounts of resources on small, tiny groups of people that have very rare diseases that used to die. And so, little babies that were born blue, or little babies that were born without working livers, or children that are born with some type of ocular melanoma that only 700 are born a year, in the entire United States. And while I'm an independent physician, so are you, Michelle, and we both, I'm sure, write off a fair amount of stuff in terms of trying to help people that can't pay. We don't have the ability to help, or we don't have the ability to expend the type of resources that are needed to save somebody who has some ocular melanoma that requires a radiation plaque to be developed that's then placed into the eye. The type of resources that it requires, there just aren't enough of those people. There's enough of a market for them, and it takes I have trouble. I mean, I'm asking you guys more so than telling you per se. How do we, what is the solution for that group of folks? Because as we become richer and more significant, if you will, nobody talks about these children in underdeveloped nations that are right now struggling with basic infrastructure and struggling with sewage, right? They have much different needs. Now we've solved all these third world problems, and now our problems are it's diminishing returns in terms of that we're focusing on these small group of people with these terrible illnesses, but that require a vast amount of resources that no Ron Paul or Anish Koka or Michelle Akkad are going to be able to fix, no matter how nice we are.
Well, I think, as you point out, first and foremost, we have the ability to even address these problems because we have the level of economic development that makes us a so-called first world nation. So that's the first thing to remember, is let's not kill the golden goose. But number two is we have to accept that there's always scarcity. There's always allocation of resources in any scenario, no matter how advanced we get with our technology. So the question becomes, who makes the decision about whether to, let's say, expend vast amounts of resources within the NHS, in let's say in Britain, or the NIH here in the United States, spend vast amounts of taxpayer resources trying to come up with a solution to a rare problem that affects 700 babies a year in the United States. Well, I can't make that decision, but I don't think a politician or a bureaucrat can either. So as imperfect as it might seem, or as unhappy as it might seem, I think we have to understand that what we want is the best possible allocation of resources based on what people truly care about and what they truly value. And in my view, the marketplace will always reflect that more than government. It's just the nature of things. People care about their own money and the people closest to them more than they care about other people's money and abstract problems.
Right. Plus, I think we have to remember that, it's the safety net pretends that they actually save people, but they, in fact, they don't, or they rarely do, or they may some, but they don't others. We had a conversation with a Canadian physician a couple of weeks ago about their healthcare system, and poor people in Canada do worse and don't get access compared to rich people, and it's the same here. So saying that we're going to have an impersonal safety net coming from the government and it's going to work, it turns out it's not. I mean, nowadays people with completely treatable diseases, if they're poor, they don't get the treatment. If they have diabetes, they don't get the treatment. It's the same thing. So we don't even have to conjure the scenario of the rare diseases. The common diseases that are treatable are not getting treated even with the diversion of funds from taxpayers. So I think would, and then I think and in truth I think they would. I mean, even corporations would. I mean, if you have like 800 kids who need a liver transplant, the corporations, if they are freed from all these obligation, their burdens that they currently have, would step up to the plate, because they had been doing that in the past. They will do this again. It's good PR for them. They will step up to the plate. It won't necessarily have to be just you on your own, or me on my own, left to my own devices to do this. There'll be large resources pulled together. I think. I think that's.
No, it seems clear.
Yeah.
It seems clear that the market is unable to be repressed, regardless of what system it is. There's a story, I think it's from within the last month, about the NHS, and the NHS. I think I'm getting this right, but the NHS instituting some type of policy to deal with this inability to get appointments in a reasonable time frame. That if you pay a certain amount of money per year, you can get same day appointments. So even in the NHS. The
right.
market shows that. And then what we're seeing, I'll try to answer my own long question in terms of this rare disease issue and what to do. As we're seeing, and one of the things, me and Michelle and a bunch of folks, a lot of folks are concerned about in terms of raising the bar for regulation in the United States, whether it be for drugs or devices, and we don't see the true cost of innovation that doesn't happen, right? What's happening as these bars are being raised, and drug companies are saying, to heck with this, we're not going to do research on this. We're just going to do a bunch of Me Too drugs that are, have marginal return, but hey, we know we're going to make a lot of money on that. You're seeing societies of patients getting together and funding their own research, so you're kind of seeing, once again, the kind of the market is seem to be unstoppable, if you will. So,
what strikes me is the way we've changed our approach to HIV drugs. But in the 80s and 90s, when AIDS was a death sentence and often a quick one, there was a sense of urgency to the research. And then some drug cocktails came along that enabled people to live years, decades, perhaps the rest of their lives just fine, not just fine, but to live with HIV. And it seems that for me, as someone who just peruses the popular press, that there's not that urgency anymore, that we sort of just live with HIV rather than trying to radically cure, I guess, what is a virus that causes it.
Right. I want to get back to the Mises Institute, maybe tell a little bit how, to me, for doctors in the audience or people listening to the show here, one of the most important thing that I've learned through the Mises Institute is the question of prices and how prices are set. And for most people, it seems to be, and I think, and for me, before I understood it, it seemed to be such an arbitrary thing or a mysterious thing, or people can set price, however they want, and this and that. As it turns out, today there was a tweet from a prominent healthcare economist who was, saying that there's a Trump mandate or a mandate from CMS to ask for price transparency. And he was belittling this as saying, well, it doesn't, it's not going to help to ask for price transparency if all that the hospitals will do is just, be transparent with their list prices, when we know that the list prices don't really reflect, what the real prices are. But the truth is that most healthcare economists support a system where real prices don't exist at all. Right? It's not just a matter of list prices versus contracted prices or whatnot. I mean, the real prices don't exist in the system at all. And most economists, from my, most mainstream economists, have this idea that, seems to have a misunderstanding of how prices are, how they should be set and how they are set, because, again, they have this sort of mathematical, empirical bias, and they think that, you can manipulate these things, perhaps with little effect, that, you can have your central planner moving the equations here and there and have the price set exactly in the sweet spot where you want it, and not understand the consequences of it. So for me, learning a little bit how human action and interactions, really, because we're social animals. We live in societies, we live in communities. We're all dependent on one another, right? And this dependence leads to exchanges, which then leads to certain prices that convey some information about the goods, the relative value of goods and services. Is just a fantastic eye-opener. And then you can't really look at things the same way. And so I want to mention that, to draw the audience to the Mises Institute website, to have them, encourage them to learn a little bit more about what prices really are, right? They're not just things that corporations, decide to set wherever they want because they're greedy, or governments can set because they're, well-meaning and they want to help the poor and they want to, they bring the prices down, that sort of thing. That's a complete distortion of reality. And so I wanted to mention that before we close. But any other comments about what the Mises Institute can contribute to the healthcare conversation? Because I think it can, just simply by providing sound principles of economics. But I think in other ways about it's very human approach to me, which we mentioned at the beginning of the show, to how we deal with one another.
Well, absolutely it is. And as you mentioned, we can first and foremost disabuse people of ideas like the labor theory of value or the cost theory of prices.
Right.
But as you say, prices are information, they're signals about how much people value things. And they're based on the meeting of supply and demand, which is constantly shifting. So prices are constantly being discovered. And when we muck about with them, when we try to set them, bad things happen, either with regard to supply or demand. We have shortages or too high prices or whatever we have. So I think the knock on doctors, and I don't know if this is true, but the knock on doctors is that they're, because of their backgrounds, because they're generally high intelligence people, that they overestimate their understanding of other fields, that they imagine themselves also quite competent in economics or also quite competent in personal investing or whatever it might be. So we have a lot of doctor fans. We're involved with Jane Orient's organization. We're involved with the Free Market Medical Association that Dr. Keith Smith runs out of his surgery center in Oklahoma City. And I hope that we can be a resource to people who really understand that there's nothing magical about the provision of healthcare or medical services. There's nothing magical about the provision of drugs that makes them different than other goods or services in the marketplace. And there's no sort of special right to compel other people to provide you with medical treatment or drugs. And that when we start insisting that, when we get into this positive rights theory of medicine, things could go downhill very quickly.
Right.
All you need to do, if you believe in single payer, if you believe in a right to health care, so-called, is visit the former Soviet Union, visit Venezuela, visit a lot of places where they wrote into law a right to health care, and see where it took them. So I hope that Mises.org is a resource and an entertaining and enjoyable and enlightening place for anybody who has an interest in this sort of thing.
Yeah, one of the big problems is that you have such ideological homogeneity among a lot of doctors because again, there's no exposure to alternative schools of thought, and the reason that's proposed is that the evidence suggests that this is the best way, and there isn't this empiric foundational basis for anything else. So the reason everyone is running around saying the same thing isn't because they're all from the same cloth, which are they're saying. But the reason they're saying is that they're super smart intellectual people who have examined the evidence objectively and have arrived at the conclusion that single payer is the best thing, that Medicaid expansion is the best thing, that the evidence says Medicare Part D is the best. So it's this constant battle against. It's not that you're having a debate; it's that you're battling against they believe that they have found the truth. This is the truth, and so it's this battle against empiricism, I guess. And do you have how do we effectively make inroads against that, would you say?
Well, I think there's plenty of empirical evidence from the former Soviet Union, from China, and from some other places that socialism and collectivism don't work too well and actually don't increase the physical, mental health, or economic well-being of anyone. So I think that's a good starting point. But, you're right. Doctors tend to be smart people, and they tend to be strong-willed people as a result.
The biggest knock, I'm sorry, Jeff, the biggest knock from my standpoint against doctors is that they believe in the labor theory of value very strongly because of licensing. Many of them feel that they've put in all these long hours and effort, many years of training, and that at the end of that, they're entitled to a certain salary. And of course, most patients, especially nowadays, are not going to be willing to sustain the lifestyle, the income of doctors they've gotten used to for so many years. And therefore, there's then a natural, look to government to provide the funds that doctors are entitled to, because they've spent so many years studying medicine and they're so smart and so forth. So I think, to me, empiricism is a problem, but and they're related. They're two different aspects of similar flaws. But the labor theory of value is the biggest one, as far as I'm concerned.
You're not making a strong argument for why doctors should be libertarian, Michel. You're saying most of us would make way less money if we were.
Yeah, I mean, the only plug is that sooner or later the market reasserts itself, and you'd better take your income cuts soon, the way I've done. Immediately, rather than wait for the whole thing to crash and be left, running around. Anyways, Jeff, it's been great to have you. Really enlightening. I'm delighted that we're giving the audience a chance to learn about the Mises Institute through this conversation. And we will have the links, the proper links on the show notes. And, we'd love to have you back. There's a lot more that can be teased out, so perhaps a little bit more technically going forward in terms of parallels between the way the medical academic views things and the way mainstream economists view things. I mean, they're very, as you mentioned earlier, the aggregate thinking about things. So thank you for joining us very much, and we hope to see you next time.